for choice 2, 4, and 4, but I just respond to the number 3 question, actually. There are very strong data coming now from the GPAR 6.2 and the recent CLGB trial presented in the last San Antonio. Was not cisplatin, by the way, it was carboplatin applied with the weekly paclitaxel 12. And there is a significant improvement in the rate of complete pathological response for those patients. So I'm not saying it's in the guidelines yet, but it's coming. But classically speaking, according now, for FEC and for Taxotere would be fine.
It's coming, but we have only one study on this subject with the platinum. Okay, Mr. Ghazali, what is your choice?
I think the best option for this lady is chemotherapy. So I will go for her for the best ever chemotherapy I can and go for FEC and for Taxotere, because if I can improve the survival of this case, it will be by chemotherapy. So I will give her the best option for FEC and for Taxotere.
Okay. So there are different possibilities for a tumor to respond to neoadjuvant chemotherapy. We can have shrinkage of the tumor. We can have shrinkage of the center, but still some fragmentation of the tumor in periphery, like that. Or you can have the tumor is like exploding, so you have fragment of tumor, but you no longer have a mass like you had at the beginning. Or you can have a complete response, or you can have, of course, a tumor that is resistant. And the tumor can be bigger than it was at the beginning or at the same size. Like here, for instance, you have a response, but it's the same size. Or it can be smaller, but with fragmentation. So here, I think MRI adds, but there is a problem of the surgical procedure. And I would be interested if Krishna comment on that. If you have a tumor that responds, but how do you define your conservative treatment?
In this case, with a very small breast.
Okay, this is a question that has no evaluation in the literature. There is no study that has compared wide local excision with extensive margins versus narrow excision with free margins. So we have no data. Our recommendation is that you try to excise the initial tumor bed. So if you do so, the question is, why do pre-op chemo? The answer is simple. If you don't do pre-op chemo, you will want to excise far away from the initial tumor. If you do pre-op chemo, you want to give the pathologist the more information possible to be sure that here and there you still are without tumor. So if this is the residual tumor, and if we can excise widely around the residual tumor, trying to demonstrate that we don't have residual foci here, I think this is the best information to give the pathologist and to give the oncologist and the patient. If this means you're going to do a massive destruction of the breast, then of course don't do it. And this is the reason why when we have partial response post-chemotherapy, we do quite a lot of oncoplastic surgeries, trying to provide the pathologist with the initial tumor bed. Once again, this has not been evaluated by providing a benefit in terms of recurrence, but we do believe that it provides a benefit in terms of information.
Sharif, what is your clinical habit in this case for the tumorectomy?
I think we would try to excise the present tumor with a good safety margin, and I will not give any interest to the original size, because this is the main policy or the main essence of giving pre-operative neoadjuvant chemotherapy. It's to take down the size of the tumor to allow a smaller resection.
I would also add the testing of key 67 to see if I'm going to change the protocol to a more aggressive one or be satisfied with the result as such. Key 67 after the neoadjuvant.
Sham?
Yes, I'm slightly surprised by the answer of Professor Krishna because usually after the neoadjuvant treatment, if I find the very good response and onion peel response by MRI and this very good shrinkage and disappearance even, and so we put the clip or the marker inside the tumor, and then after all of these, and I will remove the whole the primary tumor size. It will be surprising for me. I know that Professor Kloff has experienced it very well in oncoplasty, but after almost CR or radiological CR, even after this, we can go for removal of the primary tumor size?
Okay, the reason why we put upfront that question in our surgical groups in France is because of the relatively high recurrence rate after induction chemo with large cancer and conservative treatment. And one of the reasons that might explain that is because we could leave non-visible foci of tumor. So we're trying to provide the pathologist with a large volume. Of course, if your initial tumor is 10 centimeters, you're not going to excise 10 centimeters. But if you have an initial 4 centimeter cancer or 5 centimeter cancer, it's not a big deal to excise 5 centimeters of breast tissue. So don't get me wrong. I'm not saying you're going to excise maximal tumor initial volume, but we're trying to give the pathologist more than 2 millimeters of free margins. Maybe we are wrong, but I don't think the payoff is very expensive.
And you have the same habit for triple negative patient and luminal?
Unfortunately, we did not stratify looking at the subtypes. I don't have the answer.
Okay.
I just want to share with you this data from MD Anderson. It's a study from 2004, but it's quite interesting. You know that they have worked a lot on neoadjuvant treatment, response to neoadjuvant treatment. And here it's the recurrence, local recurrence after conservative surgery for neoadjuvant treatment, depending on the residual pattern of the tumor. And here, you have more local recurrence when you had a residual pattern that was fragmented, because probably you might have left in the periphery of the lesion some foci. And if you compare the recurrence pattern in terms of complete pathological response in blue or solitary mass, so with a response that shrinked in pink, you see that it's the same level of local recurrence. So from the statement of the NCI, one of the messages was that breast-conserving surgery should be limited to those cases in which surgery procedure is able to achieve clearly negative margins. So we went through that already. I just want to look with you another hypothesis. So we still have the 3 centimeter triple negative breast cancer in the right breast, but what we found at MRI, in fact, the patient had macrobiopsy, so she had 14 samples and a removal of the image, and it turned to be a multicystic disease, so completely benign. So does it change? It changes, your treatment option. If you had the triple negative in one breast, but no longer a cancer in the second breast. So it's exactly the same, more or less the same options. So will you go for mastectomy plus axillary dissection plus in the other breast follow-up, or mastectomy plus axillary dissection in the right breast and zonectomy in the left breast, or will you go for bilateral mastectomy or for neoadjuvant chemotherapy?
Okay. For the first one, we have only the follow-up every 6 months for the left breast. Raise your hand. We are only 3. After we have a mastectomy in the right breast, axillary clearance, and the zonectomy in the left breast. Okay, we have 4. Okay, 6. Okay. Option 3, bilateral mastectomy. neoadjuvant chemotherapy. Yes, sure.
Okay.
And do you have other option? Other option for this patient? No? In the panel, do you have another option? No. Okay. And, what is your recommendation?
Oh, neoadjuvant chemotherapy.
Yes, sure. But for the left breast. For the left breast.
For the right breast, I think
Left.
for the left, I think follow-up. She had a microbiopsy. It's the standard procedure for ACR3. But I'm not a surgeon, not a clinician.
If we have benign lesion, but with ATP, hyperplasia plus ATP, in this case, we have to do the zonectomy, no?
Yes, if we
Okay.
had atypical ductal or...
Okay, we have to finish, eh? Okay, we continue.
So the last question. This 30-year-old patient has no family history of breast cancer. Do you refer her to an oncogeneticist for BRCA testing? Yes or no?
Yes with me? No with me. I am alone. Okay?
So I think
And
Right.
Mr. Pujol.
It's cool. I will address this woman twice because actually she have two independent reasons to be addressed. The first one is that she have a triple negative. And remember what Professor Barouanoun said this morning. A single case of a triple negative breast cancer before the age of 50 is now a full indication to perform the test because we have a rate of mutation of more than 10%. And the second one, she have a bilateral cancer before the age of 35, which is also a full indication of test. Remember that the mutation could be inherited by her father, for instance, so there is no family history.
I think it's finished now. We have to thank you for your assistance, your attention, to participate. And tomorrow, at which time we will start the...
6 o'clock.
Tomorrow at 6 o'clock here.
Tomorrow it
Thank
will
you
be
very
a
much. Bye-bye.
breakfast with the BGICC faculty in the Pearl at 8 till 9, and then we will start the conference at 9. And the most important panel recommendation session will start at 5:30. Thank you very much.